It gives me great pleasure to introduce Professor Brigitte Farou, who's a professor in pulmonology, and she's head of the Pediatric and Non-Invasive Ventilation and Sleep Unit at the Necker University Hospital in Paris, France. With regards to the initial settings, what would you recommend with regards to CPAP and NIV to get started?
So again, this is based on clinical practice and experience of pediatric experts on CPAP and NIV. So in children, we privilege constant CPAP because it works very well. And also we will see that in another pediatric presentation that more complex CPAP modes like auto-tritated CPAP is not possible in very young children and children weighing less than 13 kilograms. However, in adolescents or children weighing more than 30 kilograms, auto-tritated CPAP is possible. However, there is no demonstrated superiority of auto-tritated CPAP or any complex CPAP mode in children as compared to constant CPAP. We recommend a starting pressure of 4 centimeters of water with a progressive increase. This increase, according to the tolerance and the psychology of the child, can be progressive over one afternoon, one day, and in some patients it will take maybe 1 week, and we do it progressively. We adapt to the tolerance of the child. However, the mean treatment pressure evaluated either on a titration, polysomnography or polygraphy or other criteria is around 8 plus minus 3 centimeters of water in children. We privilege also a short ramp, so a low starting pressure with a progressive increase to the optimal CPAP level, to the set CPAP level in around 5 minutes. We prefer a short ramp in order to have quite quickly the correct treatment pressure. What is very useful is the inbuilt software on the devices, and there have been some publications showing that the 90% CPAP level on an auto CPAP is best correlated with an optimal CPAP on a titration polysomnography. Also, one important question is the humidification. Again, we have no evidence-based arguments for humidification, but for a better comfort, we always use humidification, so warmed inspired air for CPAP in children. The goal is to achieve a physiological tidal volume, so a normal tidal volume for the age and the weight of the child. And approximately the goal is to achieve a tidal volume around 6 to 8 milliliters per kilogram. We prefer to start with an expiratory pressure of 4 centimeters of water and an inspiratory pressure of 8. This is largely insufficient, but it helps the child to progressively acclimatize to the inspiratory and expiratory pressure. And then we, again, as in CPAP, we increase progressively, and children can have a very good possibility to perceive and to express their tolerance of the inspiratory pressure. They can say very easily, no, I don't have enough air, I have too much air, it's too high, it's too low. And in clinical practice, the final expiratory pressure in children is between 4 and 6, and a mean inspiratory pressure of 10 to 14 centimeters of water. This pressure, of course, can be higher in adolescents with cystic fibrosis, and also higher in adolescents with severe neuromuscular disease and scoliosis, for example, or thoracic deformity. A backup rate is also recommended in case of neuromuscular disease or impaired central drive. And again, the goal is to achieve a physiological respiratory rate during sleep. So you have to take in account the age and the normal respiratory rate during sleep of the child. And we set the backup rate 2 to 3 breaths below the child's physiologic respiratory rate during sleep. If you use a trigger, which is most often the case, you must have an optimal inspiratory trigger, not too sensitive to avoid auto-triggering, and not sufficiently sensitive so that the child has to produce an effort to trigger the ventilator. Very important is also the optimal expiratory trigger, as you saw on the figure. It can be either an optimal expiratory trigger. Normally we set it around 40% of the maximal inspiratory flow, or in other children, we do it more in children with neuromuscular disease. You can set the inspiratory time between a minimal and a maximal value, or sometimes have a fixed inspiratory time, but we don't use that very much.
That's fantastic. That's a really good place to start. I just wondered whether you would mind commenting on your thoughts about rise times in children.
We set it as quick, as high as possible, in order to stop the contraction of the patient's respiratory muscles. Because if you wait too long, then the patient has finished his inspiration, and you are not unloading the respiratory muscle of the patient. So it's a balance between comfort and efficacy.